Let's be honest, abdominal X-rays can look like a total mess, right? Just a bunch of confusing gray shadows. But what if I told you there's a simple, reliable system that can turn all that chaos into a clear diagnosis? Well, stick with me for a few minutes because that's exactly what I'm going to give you.
Okay, let's just jump right in. You've got a patient who's in real trouble. Their belly is painful, it's swollen, and you need answers fast. You get this X-ray back. At first glance, it looks intimidating. But don't you worry, we're going to treat this like a diagnostic mystery, and we are going to solve it together step by step.
So, first up, the mystery itself. We're kicking things off with a real case. Because, let's face it, the best way to learn this stuff isn't just memorizing facts, it's actually putting them to use right away on a real problem. Now, you might be thinking, hey, don't we just order a CT scan for everything these days? And yeah, you're not wrong. CT and ultrasound are absolute game changers. But the good old abdominal X Ray, the AXR, is still a super important first step. It's quick, it's readily available, and for those really urgent situations like a blocked or a burst bowel, it can give you the critical answer you need, like right now.
All right, to solve our mystery, we first need to learn the language of the X-ray. And believe it or not, the secret code for every single X-ray image comes down to one really simple idea: density.
The whole concept is actually pretty straightforward. Just imagine you're shining a flashlight through different objects. Things that are really dense, like a rock, or in this case, bone, they block the light and cast a bright white shadow on the film. But things that have almost no density, like air, let the light pass right through, so they show up as black. Everything else is just a shade of gray in between. And here it is, the whole decoder ring on one slide. This is your cheat sheet. There are basically only 5 shades you need to know. Air is the blackest black. Metal, like a surgical clip or a pacemaker, is the brightest white. And then filling in the middle, you've got fat, which is a dark gray, soft tissue and fluid, which are a lighter gray, and then bone, which is white. If you can get this grayscale in your head, you are already halfway there. Okay, so we get what the different shades of gray mean, but just staring at them isn't enough. We need a plan, a system, to make sure we look at everything in the right order and don't miss anything critical. And I've got a great one for you. And here it is. It's as simple as ABCs. This little mnemonic is going to be your best friend. A is for air. Is there air outside the bowel where it shouldn't be? B is for bowel. Are the loops of bowel too big or in the wrong place? C is for calcifications in bones. Are there any weird white spots like kidney stones or any fractures? And finally, S is for soft tissues. Can you see the outlines of organs like the kidneys and liver? ABCs. You're going to use it every single time. So let's really dig into B for bowel, because knowing the difference between the small and large bowel is absolutely key. The easy way to think about it is this. The small bowel is usually jumbled up in the center of the abdomen. The large bowel kind of makes a picture frame around the outside. The small bowel has these thin lines called volvulae that go all the way across its width. They look like a stack of coins. The large bowel has thicker pouches called haustra that don't go all the way across. Okay, now for a rule you just have to memorize. It's called the 3-6-9 rule, and it's non-negotiable. The small bowel should never be wider than 3 centimeters. The large bowel shouldn't be wider than 6 centimeters, and the cecum, which is the very start of the large bowel, gets a little extra room, up to 9 centimeters. If you measure anything bigger than these numbers, you've got a major problem on your hands. That's a huge red flag. All right, we've got our code, we've got our system, we've got our rules. Now it's time to put on our detective hat. Let's do a quick fire round of the most common, most dangerous things you need to be able to spot. The red flags you just can't afford to miss. First up, small bowel obstruction. We're putting our rules to work. We're looking for those central loops of bowel that are blown up bigger than 3 centimeters. If you're lucky enough to have an upright X-ray, you'll see these incredible little straight lines of air on top of fluid, stacked one after another. It looks just like the rungs of a ladder, and it's a classic sign. Next, large bowel obstruction. This time, we're looking at that outer picture frame. If the colon is ballooning out past 6 centimeters, you know there's a blockage. And the giveaway here is that even when it's really dilated, you can usually still see those telltale haustral folds, those little pouches. Now, I'm about to show you a sign that I promise you, once you see it, you will never, ever forget it. If you look at an abdominal X-ray and you see something that looks exactly like a giant coffee bean, you're looking at a true surgical emergency. So this coffee bean sign is the classic calling card for something called a sigmoid volvulus. What's happening is a long, floppy part of the colon has literally twisted around itself. It's just like kinking a garden hose. Not only is the bowel blocked, but the twist is cutting off its own blood supply. This is incredibly dangerous. Our last major red flag is something called pneumoperitoneum. It's a fancy word, but it just means air in the peritoneum, or free air floating around inside the abdomen. This is a 5-alarm fire because it means the bowel has a hole in it. If the patient is sitting up, you'll see this beautiful, easy-to-spot crescent of black air right underneath the diaphragm. If they're lying down, you have to look for something a bit more subtle called Wriggler's sign. That's where you can see both sides of the bowel wall because there's air on the inside and air on the outside outlining it. Okay, we have built our diagnostic toolkit. We know the code, we've got the ABC system, and we know the major red flags to look for. It's time. Let's go back to our patient and finally solve this case. So here we are again, back where we started. Our patient with the painful, swollen abdomen. Except this time, it doesn't look like just a random jumble of shadows, does it? Let's walk through our ABC system together and see what pops out. Okay, first, A for air. And whoa, there is a ton of gas on this film, no doubt about it. But is it free air? Are we seeing that crescent under the diaphragm or Wriggler sign? No, doesn't look like it. All this air seems to be trapped inside the bowel. Next, B for bowel, and bam! There it is. This is where it all becomes crystal clear. We have one single enormous loop of bowel that's just dominating the entire image. And what does it look like? It's our coffee bean. It's unmistakable. And notice how it's so stretched out that all those normal haustral folds are completely gone, just smoothed away. All right, let's just quickly run through the rest. C for calcifications and bones. I'm scanning around. I don't see any obvious kidney stones or other weird white spots. The bones we can see, like the spine and the pelvis, they look totally fine. And finally, S for soft tissues. Well, that giant gas-filled coffee bean is so big that it's pretty much hiding everything else. We can't really make out the edges of the kidneys or the psoas muscles. The main problem is literally overshadowing everything. So when we put all the pieces together, our ABCS system points to one and only one conclusion. The diagnosis is a sigmoid volvulus. That classic, impossible-to-miss coffee bean sign tells us this is a surgical emergency. See? Our system worked perfectly. And there you have it. What started out as a confusing, chaotic image is now a clear, confident, and life-saving diagnosis. That is the incredible power of having a system. It takes the chaos and turns it into clarity. So the only question left is, what medical puzzle should we take on and demystify next?